Hi, good evening. This is Dr. Raman here, welcoming you for the latest session of our international webinars. And we have got a power-packed speaker forum and an excellent power-packed eminent faculty. And we are interdisciplinary as usual. We have our guests from various countries. We have delegates from various countries. And today's program is on iatrogenic injuries of the pediatric larynx. To use a cliche, I mean, prevention is better than cure. So all those complex surgeries that we do, maybe at least part of them can be prevented by better and safe practices in the intensive care units and in the ORs. Now, the topics that we have today are on iatrogenic intubation injuries, iatrogenic tracheostomy injuries, iatrogenic laser injuries, and then we have a panel after that. Let me introduce to you the panel first. We have Dr. Michael Crow from the Birmingham Hospital, and he's a well-known airway surgeon, pediatric otolaryngologist of repute from the United Kingdom. We have Dr. Moghira Siddiqui from the Aga Khan Institute of Medical Sciences from Karachi, Pakistan, so that we have a subcontinental perspective to the whole thing, and we have guests joining from Sri Lanka and from Nepal too. Dr. Moghira, we're really delighted to have you here to share our experiences with you. Then we have Dr. Ashwath, who's a consultant pediatric intensivist of repute from India, from my own institution, the Manipal Hospital, who's part of the Children's Airway and Swallowing program that we have. Welcome, Dr. Ashwath. And then we have Dr. Pratap Chandra, consulting neonatologist, who's a chief neonatologist of a group of hospitals called the Motherhood hospitals. Who's a passionate about academics. We welcome you, Dr. Pratap. And going to our speakers, our first speaker is Dr. Karthik Balakrishnan, who needs no introduction to this audience. We fortunately have a captive audience. Keep signing up for the Sunday torture every week. And we thank you for that, for joining us. And I hope all your marital status is fine and we haven't altered it. And now, Karthik is from the University of Stanford, trained at all the best institutions, and an airway surgeon of international repute, who has written a lot of wonderful papers, which I've personally read and recommend to you in future also. Dr. Karthik Balakrishnan is going to give a talk on the iatrogenic intubation injuries. And without much ado, I request Dr. Karthik to start the proceedings. Thank you, Dr. Karthik, for accepting our invitation.
Dr. Raman, thanks so much for the chance to join again. I appreciate you asking me back after the previous presentations. Let's see here. Let's share the screen. Okay. So, yes, we'll talk briefly today about intubation injuries. So just a quick overview. We'll talk briefly about the basic physiology of intubation injury, and then follow that with the discussion of specific types of injuries, namely those related to insertion of the endotracheal tube, those related to the presence or position of the shaft of the tube, and then those related to the presence and inflation of the cuff of the tube, because those are all slightly different. So, you know, in general, endotracheal tubes are our friends, as our neonatology colleague on the call can attest far better than any of us. They've been a huge factor in increased neonatal survival, especially of the premature population. Our NICUs around the world are demonstrating ongoing increases in their ability to manage children who are who have intubation for a prolonged period of time, who need prolonged mechanical ventilation, and so on. And in many cases, those children escape without a tracheostomy, which is a testament to that skill of our neonatology colleagues. Of course, we all use endotracheal tubes as airway stents after reconstruction and for many other purposes as well. But as we've all come to realize, this increased use and reliance on endotracheal tubes for airway management does have a dark side. And so when we think about the basic physiology of intubation injury, The key point, at least for the subglottis and trachea, is that the capillary pressure, the capillary perfusion pressure is about 20 to 25 centimeters of water. And in addition, the tube and the cuff are not stationary objects in the airway lumen. They move. They move anteroposteriorly, side to side, and then in and out in a shearing motion, which is one reason why some of us prefer nasotracheal intubation rather than orotracheal intubation, because that increased fixation in the nasal cavity may reduce some of the in and out shearing of the tube when the child turns their head, for example. And of course, we have to balance that movement and the risks thereof against the risks of more deep sedation, for instance, for a child who has a prolonged intubation. And when we think about the cuff in particular, if the local pressure by the cuff against the mucosa exceeds that mucosal capillary pressure, then you have ischemia. And that in turn can lead to necrosis and ulceration of the mucosa. Or in some cases, even more deep necrosis and breakdown of the cartilage itself. But if the mucosa breaks down, then you get exposed and inflamed cartilage, which leads to granulation tissue formation. And the granulation itself, as we all know, can lead to direct narrowing or obstruction of the airway. But in addition, if left alone, the granulation tissue can evolve into a more long-term fibrotic stenosis as well. So now let's focus on the different types of injuries. And this is, of course, just an overview. I'm sure we've all seen other types of injuries that don't fall into these categories, but these were the main ones that came to mind. So we'll talk a little bit about arytenoid subluxation and dislocation. We'll talk about injuries to the vocal folds themselves, and then injuries to the wall of the trachea and esophagus, and then finally injuries to the palate, only because while not an airway injury per se that we might think about, we do see them fairly frequently and have to manage them as well. So arytenoid subluxation and dislocation is not a very common intubation injury, but when it does happen, it can be quite problematic. And the idea here is simply that the tip of the endotracheal tube upon insertion catches the arytenoid either with the arytenoid tip inside the lumen of the tube or the edge of the tube catching the arytenoid. And then with the force of insertion, that arytenoid is subluxed or dislocated from its normal position in the cricoarytenoid joint. And you see a picture here on the right side that demonstrates that quite nicely, with the left arytenoid being tipped forward and somewhat medially and hooding over the glottis a little bit. In some cases, this may be amenable to closed reduction, and here's one technique demonstrated here in this picture on the bottom left, where you use the laryngoscope blade to catch the arytenoid and essentially rotate the blade and lift to pop the arytenoid back into position. These authors reported actually quite a good success rate with that, at least in adult patients, but depending on the severity of the injury and the duration that it's been there, that may or may not be successful because the joint itself may be damaged or scar. And in some cases, treatment will require suturepexy of the arytenoid or open fixation even, or partial arytenoidectomy in some cases if it's truly obstructive and a fixed joint. So another thing that can happen with insertion of the tube is vocal fold tear or avulsion. Again, not a very common injury, but certainly can happen, especially if the tube is inserted in a panic and emergency with a great deal of force, for instance. And management of this is generally done similar to glottic trauma. So if the vocal ligament and mucosa are significantly disrupted, then it's worth trying to repair them. There are reports of using fibrin glue to get the mucosa to lay back in place and stay until it heals. But the literature suggests that many of these kids will need ongoing voice therapy, in some case medialization or injection of the cords and so on. And certainly long-term follow-up is required to ensure that the voice and swallow outcomes are optimized. And then, of course, we have all probably seen tracheal and esophageal perforation from endotracheal tube insertion. Again, usually a result of an emergent intubation, but not always. In some cases, inexperienced intubators or even very experienced folks can place the tube and simply push against some resistance. And it turns out in young children, it doesn't take much force to tear the wall of the airway, or if it's an inadvertent esophageal intubation, to tear the wall of the esophagus. So our practice is to generally manage these as you would with other perforations. Usually bypassing them and giving it time will lead to healing. You can see in the upper right, this is my colleague Paul Besch, who's a pulmonologist now at Mayo Clinic. And he's this, what appears to be a very long endotracheal tube. And the idea there is in some larger children especially, again, we may want that nasotracheal intubation to minimize movement of the tube while things are healing. And so you need an extra long tube to be able to do that and bypass any tracheal injury. And so you can see that what we've done here is taken the adapter from an endotracheal tube and cut the small end off of it and used it as a connector to connect two endotracheal tubes together. Usually the distal one is the cuffed tube, of course, and then proximally you can use an uncuffed tube, and then you connect with this adapter, sew them together as well, and now you have a double length tube with a cuff on the end. This is actually a really useful strategy. I've used it several times for various purposes. But one thing to keep in mind there is, especially in young babies, you can make the more distal tube smaller or larger than the proximal tube. So for instance, if in a very young infant, if their nasal cavity is small, then you can make the proximal tube half a size smaller so that it doesn't cause alar necrosis, whereas the larger portion of the distal tube sits in the tracheal lumen, things like that. So lots of tricks you can do there. But this is an example from Doug Seidel, because he had pretty pictures of this, but this is a kid who had a posterior tracheal tear, and they managed it similar to what I'm describing with a slightly more distal intubation, in this case actually a main intubation with ventilation of the contralateral side through the Murphy eye with this long double length type of tube. And then you can see after some time the defect is starting to heal, and then here is 1 month post-injury. You can see the glottis is a little beat up from intubation, but as we go down, this defect has now healed nicely and filled in with a relatively thin, you can see it's slightly translucent wall of tissue, but it's healed and the child is extubated. And we recently at Stanford had a kid with a really bad esophageal tear due to a similar event with a panicked intubation. And again, just keeping the child intubated and then bypassing the esophageal injury with the nasogastric feeding tube. And the tear healed fine. And we've had this experience with tracheal tears as well. So it's not too common, you have to repair them. Okay, but sometimes just waiting and intubating past that area is not successful. So here's a patient who had a more proximal tracheal tear and was managed with intubation beyond that defect. And a month later, you can see that the defect has healed to some degree, but there's still an open passageway here to the mediastinum. So waiting is not always 100% successful, but even some degree of reduction of the defect is good when you have to come back and reconstruct them. And then finally, just as a slight side note, palate injuries. Again, I borrowed this picture just because the pictures I have of it are quite ugly, but video laryngoscopes greatly increase this risk. So for people who use the Storrs CMAX system or the Glide scope or any other video laryngoscope, we often find our residents get called fairly frequently to see these injuries. And what happens is basically people look at the screen of the video laryngoscope as they insert the blade and insert the tube. They don't look into the mouth as you normally would. And so they don't realize where the palate sits, and they end up spearing the palate or the tonsillar pillar. And here's in this picture, you can see the endotracheal tube actually going through the tonsillar pillar and the tonsil on its way to the larynx. So the way I teach our residents and our anesthesiology residents and so on is to use the video laryngoscope just like a regular laryngoscope and look in the mouth, pretend there's no screen until the laryngoscope is in position. and then insert the tube, look at the screen. And I think the issue that these pre-curved rigid stylets that come with these video laryngoscopes are like spears. They're incredibly rigid and very good at tearing through pediatric tissue. Anyway, now when we talk about injuries related to the shaft of the endotracheal tube, we can think about edema, granulation, posterior glottic injury, or cricoarytenoid joint problems. Of course, the best way to prevent this is to use a smaller tube, but depending on the patient's needs and perhaps the specialty of the person inserting it, a larger tube may be preferred. We certainly find, for example, that our cardiac anesthesiology colleagues love having outlandishly huge tubes in many cases, and it's a bit of a negotiation sometimes to decide what size tube to put in a given child. But edema and granulation are kind of the most common, those related to friction and pressure against the glottis, especially. And so here's some kind of horrible looking pictures of tracheal injury, in this case from pressure and friction. And so, edema, sometimes you just have to wait or treat with systemic steroids. We'll talk briefly in a second about topical therapy for that. When it comes to granulation, it is quite reasonable to pick away some of that granulation, both to open the airway lumen and to hopefully prevent bands of scar from forming. But you want to remove only the projecting fronds and not tear away adjacent healthy mucosa. Generally, this is done pretty easily with cup forceps or optical foreign body forceps. I know some people use the laser and so on, but I would hesitate to do that and create more adjacent injury. Topical therapy, there's various antibiotic and steroid combinations. At least in the US, these are all off-label uses, and we have some early data for this, but it's not yet published. It's just been presented. There's different ways to do it. So some people have used nebulized Ciprodex. The group from Boston has published on that. Ciprodex is a combination of ciprofloxacin and dexamethasone, of course. With tracheostomy tubes, you can just administer antibiotic steroid eardrops directly through the tube or around it. And if you want to get it above the tube into the subglottis, for instance, it's going to induce a cough when you drip it in. So you drip it in and then cover the trach for a second, and the child can cough it around the tube in some cases. We commonly use Tobradex ointment, so a combination of tobramycin and dexamethasone. That's an ophthalmic formulation. And Doug and I, for instance, use this a lot. And we like this because it is an ointment. It stays around a little bit longer. So if a child has a lot of laryngeal edema around an endotracheal tube and you're trying to facilitate their extubation, you can do a laryngoscopy and essentially squirt it around there into the subglottis and glottis. There's a theoretical concern for lipid pneumonia due to the ointment itself falling into the lungs, but we've never seen it. We use this quite a lot. So I think it may be more of a theoretical concern. And so here's an example. This is a patient who had influenza and was intubated and had failed 2 extubations. We were consulted actually for tracheostomy, but we thought we would try this instead. And so you can see the larynx looks fairly terrible. There's a lot of subglottic and infraglottic edema and some flat granulation. So we reintubated with a smaller tube and applied the Tobradex. And 3 days later, things are starting to cool down, but it still looks narrow. So we did a second application, and 5 days later, the kid was able to extubate, and you can see that 2 weeks later, things have healed. Now it's still mildly narrow in the infraglottis, but the child was asymptomatic from this and did not need a tracheostomy. Endoscopic cricoid split is another option. Now, we've all, I think, done open cricoids, anterior cricoid split for subglottic edema in a newborn who's not extubating well. And that success rate for extubation is pretty broad range, 27 to 75%, depending on the series. Endoscopic anterior and posterior cricoid split has been described for other indications, including vocal fold immobility and more mature stenoses, or to facilitate graft placement. But it has been used in some cases in this circumstance with post-intubation edema and has been used successfully. In one series, it facilitated 2/3 patients to go to extubation after endoscopic anterior cricoid split only. And so the thought is that by doing a posterior split as well, you just reduce the springiness of the cricoid so things can stay open. The technique here, you do suspension laryngoscopy. You use your non-dominant hand to provide some anterior pressure to the larynx. The other hand uses a sickle knife or blitzer knife to split that anterior cricoid. If you're going to do a posterior split, you just use the sickle to do that as well. And then you do a balloon dilation if possible to ensure that you've actually completed that split. And then you leave the child intubated for some period of time afterwards. All right, how about posterior glottic injury? We're almost done here, so thanks for your patience. So the issue here is that endotracheal tubes tend to sit posteriorly. Most intubated children are lying supine to some degree, and so gravity tends to pull the tube to the posterior glottis, and then it's also just a wider space, and so the tube tends to settle there. And so the result is that you get irritation at the vocal processes, and you can get granulomas, which then can lead to a stenosis. And you see on this upper right one example of a post-intubation posterior glottic stenosis coming from just behind the vocal process and filling the posterior glottis. And so many of you are aware that there's actually a classification system for this called the Bogdasarian classification. And this describes kind of 4 stages. The first being a posterior glottic scar band with an opening behind it, so just basically between the 2 vocal processes. The second would be that the posterior glottis is filled with the scar band without a posterior opening. Third is involvement of one cricoarytenoid joint in terms of stiffness or fixation, and fourth is bilateral involvement. Yes, as Dr. Kanotra said, the blitzer knife in the chat, somebody had asked, what is the blitzer knife? It's essentially a disposable knife with a slightly sharper curve to the sickle. So it's a little bit easier to hook scar bands and cut them, for instance, or hook the cricoid and cut it. One study, Dr. Vijayshekaran here, who's on the call here, published a study several years ago when he was at Cincinnati, I think, that showed that in infants and neonates who are intubated, the cricoarytenoid joints may show debris, blood products, and other inflammatory indicators as soon as 20 to 21 days after initiation of intubation. And we know that some of these kids are intubated for much longer. So certainly cricoarytenoid joint involvement after intubation is very possible and is worth checking. How about posterior? Yeah, and so you can see here an image, I'm sorry, of the vocal process just being a pressure point and being a focal area of irritation and injury from intubation. Posterior glottic diastasis is kind of a slightly different story, where instead of creating granulation, the tube creates an erosion in the posterior glottis. And so the mucosa and submucosa and sometimes part of the posterior cricoid cartilage and interorytenoid muscle are eroded away. And so you end up with this big furrow in the back. And this can cause prolonged dysphonia or dysphagia in children and even into adolescence and onward. So important consideration and something to follow in kids who have been intubated for a long time. How do you deal with it? Well, in some kids, you can actually identify a submucosal plane here and inject filler materials. But in many of them, that plane is obliterated and you just have this thin layer of mucosa that's firmly scarred onto the underlying cartilage. And so in that case, you can either consider a posterior cricoid reduction, where you go and essentially remove a midline strip of the posterior cricoid and resuture it, or you can do aryepiglottic flaps, where you take the portion of the tip of the arytenoid and bring it down in to fill this area, or extend that flap along the aryepiglottic fold, even to incorporate some of the edge of the epiglottic cartilage, and rotate that as a pedicled flap down into the posterior glottis to fill this area, and that can be quite successful. Dr. Rakesh said, how's your experience with natifloxacin ointment in the airway? I have to admit, we don't have that. So we typically just use the tobramycin, but I apologize, I cannot comment on that. All right, let's see. Injuries related to the endotracheal tube cuff in the meantime. Yes, so, sorry, Deepak mentioned the idea of antibiotics is to reduce biofilms rather than treating an infection. That is true, and there are some antibiotics, fluoroquinolones in particular, that have been suggested to also reduce fibrosis and fibroblast activity. So there may be some benefits beyond the biofilm aspect as well. Injuries related to the ET tube cuff, meanwhile, we discussed earlier that pathophysiology when the cuff pressure exceeds the capillary perfusion pressure of the airway mucosa. And this commonly leads to subglottic or tracheal stenosis, which we're all familiar with kind of the usual treatment options that are discussed, including endoscopic approaches and open. That full range of treatment for airway stenosis as we typically think about it. One example you can see on the upper right here, this is a child who was abused and had a brain injury, was subsequently intubated for a very short time. This kid was intubated for about 36 hours. And you can see his subglottis here. It's not hard to get an airway injury, especially if the tube is inserted forcefully in an emergent situation, as it was in this case, or if the tube is either too large or the cuff is overfilled. You can also get mucosal injury with crusting. And you can see this example in the lower picture where this kid did not actually have a true stenosis, but simply had terrible crusting from the mucosal injury from the tube that subsequently caused airway obstruction. And we have had patients who actually had full thickness necrosis of the tracheal wall, including the cartilage, with a direct communication with the mediastinum. In some cases, these defects have been huge, several centimeters because of the size of the cuff. And so again, you can sometimes manage that with intubation beyond the defect, or you can sometimes use a covered stent to cover the defect and temporize. And once the defect fills in and the scarring process stabilizes, which can take weeks, then you can consider how to reconstruct. But these kids often need reconstruction because if there's enough cartilage missing, the airway is just destabilized. And that scar, if it's a big enough hole, typically is not going to be enough to stabilize the wall of the airway and prevent severe dynamic obstruction. So that's what I have for you today. Certainly welcome any comments, or please feel free to get in touch anytime through the WhatsApp group or otherwise, and we can talk more.
Thank you, Karthik, for that wonderful talk covering all aspects of intubation injuries. We have some experts in the panel. I just seek some comments from them, and we also have Dr. Shan Vijayshekaran from Perth, who's been our major supporter in our charitable airway program, and he's also here, along with Dr. Jayashree, who's part of our anesthetic team from the Children's Airway and Swallowing Center, and so is Deepak. He's another major partner in crime in all the airway work that we've been doing in India for the last 19 years. And Shan, would you like to tell us any comments on your experience in terms of intubation trauma related?
Yeah, I mean, I think, Karthik did a great job covering most of it. One of the big issues is tracheal tube. Some of our team published a paper looking at a whole bunch of kids who'd had intubation-related injuries. And one of the biggest risk factors was the ratio of the size of the endotracheal tube to the gestational age of the baby. And basically, if there was more likely to, 6 times more likely to cause. So I can share that if you give me a moment. But essentially, so if you had a 30-week-old baby and you had a millimeter endotracheal tube in, the ratio is 0.1 to relatively safe. Bigger tube in, so if you had a 25-week gestation baby and you had a 3-millimeter tube in, the ratio is greater than 0.1. That's the Nelson ratio. And that massively increases your risk of developing a subglottic stenosis. I'll show you that was a case control study we published a few years ago. So that really has made us move towards using smaller tubes with low pressure cuffs. And we haven't, that second paper, which is a randomized study looking at the use of cuffs, is just in publication. It hasn't been published yet, but that certainly shows that using a smaller tube with a low pressure cuff and careful monitoring of cuff pressure reduces your risk of glottic and subglottic injury. I'll share the first paper's reference in the chat soon. The second paper, we'll have to wait till it's published, hopefully sometime later on this year or early next year.
Shan. Now we move to Dr. Pratap. Pratap, you run busy in ICUs. Are there any protocols you follow to avoid injuries? And I'm sure there must be situations where emergency intubations are done not by very experienced people in places which do not have enough facilities or people are not skilled enough. So how do you, what's been your experience in the neonatal age group?
Thank you, Dr. Raman. I think Karthik has covered quite a lot, and Shane also suggested about the size of the tube. So I think that's one of the most important things. And as a thumb rule, when I go to teach in the peripheries, what I do is for a baby who's 1 kg, 2 kg, 3 kg, you take it as the 2.5, less than 2.5. 3 and 3.5 kgs as 3.5 millimeters as some of the the guide for the cuff, the ET tube size. And also we see of times not just the insertional injury, it's also the depth with which they go into. Majority of the times they would have done a right-sided intubation, and that would result in a lot of times pneumothoraces because of the high pressure usage onto the one side of the lungs. And again, we teach them 1 kg, 2 kg, and 3 kg as fixing at the lips at 7 centimeters, 8 centimeters, and 9 centimeters. This is like a rule of thumb. And then obviously, making sure that they do the X-rays and also checking. Sometimes, in centers like ours, we do a lot of ultrasound, bedside ultrasound, to check the position of the tubes before fixing them. See, there were points raised about the nasal intubation. I don't think majority in India, especially in the neonatal age group, we don't do nasal intubation, and mainly because of people are not used to doing it. And even during my training in England, also majority of the units never did a nasal intubation. One of the things that we are looking at now is in the neonatal age group, especially in borderline preterm babies and in very preterm babies. What I'm thinking of is about 28 to about 37 weeks of gestation. These are tiny babies, and a lot of them, if they present to us with respiratory distress and also, not very severe for us to ventilate for longer periods of time, but only has got surfactant deficiency changes on the chest X-rays. So we tend to now use quite a lot of techniques called INSURE method, the LISA method, or the MIST method. So where we just intubate, give surfactant, and take the tubes out. Here, one of the commonest things that we are seeing, Dr. Raman, nowadays is, these babies will not be sedated, and majority of these babies definitely will not have received the muzzle relaxants. And this is the place where I think the babies tend to fight quite a lot, and if we are not skillful enough, I think there are a lot of, soft tissue injuries, the injuries around the pharynx, and also, when the babies are crying because you're actually doing this intubation without the muscle relaxation and sedation, you just have to wait for them to take one deep breath, and then you have to insert the tube in. I'm sure all your ENT specialists will know about all that. So when we do that, if people who are a little inexperienced, they can actually cause quite a lot of injury to the folds as well as the joints and also the vocal cords. So this has become a very big challenge for us. I think we have circumvented to a certain extent the long-term ventilation, because none of us prefer long-term ventilation now, and we go for what do you call the volume guaranteed ventilation, and then take them off as soon as possible. This is avoiding quite a lot of what we used to see in the previous era of subglottic stenosis. But now we are encountering more and more of this, the airway injuries because of intubation. especially in a baby who's not muscle relaxed as well as not received the sedation. And one of the ways that we circumvent this problem is if we have injured the area, we tend to ventilate for about a day, prepare the vocal cords and the larynx by giving, we call it as peri-extubation dose of dexamethasone, just about 150 micrograms per kg per dose, just about 8 hours before your planned intubation, around the time of extubation, and then 6 to 8 hours post extubation if it is needed. We also go in for adrenaline nebulization in case if the stridor is very big. So these are some of the issues that we face in the neonatal world, Dr. Raman.
Thank you. Michael, what is your perspective from your experience in Birmingham? Have the intubation injuries gone down with the training of people, or is there protocols which you have in place?
I mean, I think undoubtedly the instances has decreased actually in my time in practice, probably nearly 20 years. Everybody gives anti-reflux medication now for almost everything. I'd like to think that actually instinctively it would be sensible, because not having a ton of acid slobbering around the back is going to reduce adding any insult to injury. But we've long wondered if there's any way of actually working out whether it makes any difference or not. But I suppose the numbers don't really make it possible to have a randomized trial. Intubated baby gets ranitidine, or well, not ranitidine now, but I mean gets PPI or not. It's interesting. We have in my city, we have a neonatal unit and a pediatric intensive care unit in two geographically different places, as your colleague will know. Neonatologists, for some reason, never put nasotracheal tubes in. Pediatric intensivists always put nasotracheal tubes in. So they come over from the neonatal unit with an orotracheal tube, and the first thing they do, the pediatric intensivist, is to switch it to a nasotracheal tube. And I have wondered whether actually the increased use of nasotracheal tube has caused posterior glottic stenosis and anterior by the way that the tube hangs. We have tried with micro cuff tubes. Of course, it's not up to me. Our pediatric intensivists have found it difficult to monitor the pressure in micro cuff tubes. And I suppose it's like trying something new. It's very difficult to persuade a 28-member faculty of the pediatric intensive care unit to change, well, quite a dramatic change, I suppose, from what they know with cuff tubes to micro cuff tubes. And I totally agree with Shian. The trouble, of course, is that because nobody likes change, the instinct is when there is not enough seal to get sufficient ventilatory pressure, the instinctive thing is to put a bigger tube in, rather than thinking, actually, I wonder whether we could replace it with a micro cuff tube, simply because it's not something we use all the time. I suppose it's almost like whether you use navigation for surgery. If you don't use it for the simple cases, when the chips are down, you're not going to use it. So actually, in a way, if we move to something like smaller tubes and micro cuffs, we need to persuade the intensivists that actually, when times are good, we should use it, so that when times are bad, they can actually, they'll be more comfortable to use it. But I'm near retirement. That's not a battle I'm going to be fighting with the intensivists.
Now I think we need to get in Ashwath. Ashwath, what's the feedback from, what was the opinion of the pediatric intensivist? How do you, you have set protocols to avoid these injuries? Of course, you must be having. So how do you train your people under you?
I think, Dr. Raman, most of it was already covered by Pratap as well as Michael. And one thing I felt, the thing which we follow regularly is to check the cuff pressures every 6 hours. I think that makes a huge difference in the patients, because when we have a child having some leak, it's easy, first thing people goes inflate the cuff and say, let's leave it like that. So the nurses are very keen. They keep monitoring the cuff pressures every 6 hours. Thereby, I think our airway injuries is very less, even if they are prolongedly ventilated. even if after 2 weeks, we really need addressing for the airway injuries. Most of our airway patients, like you know, Dr. Raman, is from the referrals we get rather than in-house what we face. One is we tend to intubate the children fairly muzzle relaxed. See, like in neonatal practice, they tend not to give muzzle relaxations. And we would want the child completely flat and assess that they are flat enough until unless there's an airway concerns where we will have an airway backup team. The child will be intubated most likely in the theater with the ENT and the anesthetist present. So the more precautions we take, the lesser likely we're going to have injuries with these children, I feel.
Right. Thank you. And we go to Dr. Moghira. Dr. Moghira from Karachi. Are you there? Yeah. What has been your experience? Because you know we face similar problems both our countries. So can you share whether is this a major problem for you?
To be very true, we don't get those much of problems. However, there is something I'd like to mention is in this COVID era, and all those PPEs and those gadgets that we use, I think the visibility of the statist and the residents to the airway has really been a considerable problem. Like for example of some new gadgets that have come in practice. One of them is a Moghira laryngoscope. I've always found them struggling when they're trying to look at the screen. Karthik told in his presentation, they should try go in directly and then look at the screen. So with all those PPEs, I think the visibility has been more what we have seen more in these times is some mucosal injuries that did it. Other thing that I would like to mention is the use of stylets or the stylet while intubation. And I think a lot to be done in terms of training to put the angle right. And I've seen them going and hitting the anterior wall because the curve that they made to get into things was too sharp. And so there are a few comments I wanted to make.
Thank you. Deepak, any comments?
Yeah, great.
Is there a major difference between neonates and pediatric age group? That's another thing I want to know regarding the injuries.
So, no, it depends. I don't think there is any difference in the injury, whether it's neonate or pediatric as such, because it's typically because of how the user has done and caused the injury. One question I would like to raise, especially with all the panelists as well, is especially as ENT, we might take the kid to the OR and we see a various range of things happening. So you might see a simple early granulation to somewhere where the cricoid is completely exposed. And what are the different things we would do with that? Because like Karthik said, if you have fronds of granulation, just touch them. So I typically am very minimalistic with the granulation tissue. I would take it out only if it is obstructing the airway and let the body heal rather than being very aggressive about it, similar to what Karthik said. The similar thing would be for what would you do when the cartilage is exposed. So typically for me, again, it's been shown on animal studies that once the cricoid cartilage is exposed, the risk of subglottic stenosis goes much higher because it causes perichondritis, and then it causes the chances of it becoming a formal scar tissue is much higher. So those are the ones, even if I don't do right away anything or maybe treat them on medical treatment, the crucial thing would be to bring them back in 3 weeks. So bring them back in about 3 to 4 weeks to reassess that subglottis to make sure there is no subglottic scarring happening, because at that point you can do balloon dilation or any other adjunctive procedures to help reduce that. So for the intubation injuries, that is quite important. And the other question, whether what we use around the subglottic edema, I think one thing which has shown is some form of steroid definitely helps. That has been like across various centers. We know how we introduce them depends on your own experience. So whether you inject some Kenalog into it, whether you put some ointment around it, whether you give Ciprodex nebs or Tobradex nebs or whatever, I think any of those combinations will work as long as there is some form of steroid going in there.
Yeah. I'm sure Kishore has got a lot of experience in this area. Kishore, you would like to share some of your thoughts on injuries?
Thank you. I think Karthik and the intensive actually done a good job as far as covering the pathophysiology of the lesions. Just a couple of things which I think are important is a bilateral circumferential lesion in the subglottis or the trachea. This is totally different from a florid lesion, either on one side or anteriorly. So I think a circumferential lesion, posterior commissure lesions, florid lesions which are in the posterior commissure, which probably have got a tendency to go into one or both cricoretinoid joints. This is one sort of group of granulation tissue involved lesions. The second group are large or small, uni or bilateral, circumferential subglottic retention cysts. Treatment should be based depending upon where and how these lesions are based. The third are tip of the tube lesions, because those eventually go into a circumferential stenosis along with the cuff lesions. So I think there are these 4 different varieties. So eventually for me, it is patient factor, because if you have a cardiogenic issue, then as we know that anemia and all kinds of vascularity problems, they eventually increase the formation of granulation tissue. The second part, which is extremely important, is there are sometimes an issue where everything has been done, the corticosteroids and this and that, and eventually a decision has to be taken to do a tracheostomy. So I think the site of doing a tracheostomy is extremely critical. When to do a tracheostomy is critical. And number 3, for me, it is extremely critical to treat the proximal lesions in the larynx, put in a stent whilst we have done a distal tracheostomy, because eventually what we want is the entire larynx to heal in an open or an abducted phase. Otherwise, we do a tracheostomy lower down and end up not actually addressing the larynx and the subglottis. That is where the whole problems are. So that is a sure shot sort of, situation that leads into a full-blown cicatricial stenosis. So I think tracheostomy in extremely difficult situations is something that we really need to think about. And I think overall, talking to the intensivist to reduce the intubation lesions, we as surgeons taking care of incipient stenosis. And number 3 is eventually if a tracheostomy has to be done, then having a very clear idea what and where the tracheostomy should be done and how we treat the proximal lesions in the larynx.
Now, how the timing is important. Timing, Kishore?
Yeah, sorry, I didn't hear that.
Timing of intervention in these cases.
Well, I think it all depends upon the floridity of the lesions. If they are extremely dense, so I would give them 1 or 2 sort of shots of treating, and then eventually it depends really on our discussions with our intensive colleagues. Neurological cases, bad prognosis. Eventually, I think it is going to go and it is going to require long-term intubation. So I think those are the cases that we will sort of do a tracheostomy early. Other cases will be taken case by case, but as I said, that you shouldn't do the tracheostomy and forget the lesions in the larynx, especially if they are extremely florid, because they need to be treated as well. And to me, stenting proximally with a distal tracheostomy is the way forward. As far as the period is concerned, it could be anywhere between 3 weeks to honestly 3 months or even more. So it's really something depends. The basic, that's where the patient factors start coming in. How is his medical condition? What is the prognosis? Is it a degenerating condition? I mean, all those things we'll have to discuss with the intensivist.
Right, thank you. I think we need to go to the next topic, and we'll invite comments from the other panelists as we progress. I introduced Dr. Sohit Kanotra. He's the professor in the University of Iowa who's been with us from the beginning of the webinars, and he's been another resource person who's been newly recruited, and he's going to talk to us about tracheostomy related injuries. And I think that's another very important topic for all of us, including intensivists and neonatologists. So I think I won't stand in the way of Sohit's talk. Sohit?
Thanks, Dr. Raman. I'm just going to share my screen. Great. Yeah, so thanks, Dr. Raman, for the invitation. I think this has been a great initiative by you. It's a great honor to be a part of this program. I come from University of Iowa. I'm going to talk about complications of pediatric tracheostomy. I know the topic was on iatrogenic complications only, but I'll cover a little bit more broad-based other complications which we see in tracheostomy and how to actually avoid them. One of the things our university is known for is our head and neck protocols, and most of the surgical discussions which I'm going to have today are actually available on our head and neck protocols. So what we are going to discuss initially is some nuances of how we do a pediatric tracheostomy, and I'm going to tell my way of doing the pediatric tracheostomy. Some of the complications associated with pediatric tracheostomy, how to manage those complications and how we can avoid those complications. And then how to understand how multidisciplinary management is required in pediatric tracheostomy to actually reduce your complications. So the indications of tracheostomy has actually changed significantly over the last 2 or 3 decades. Previously, it was more for infectious causes, and now since we are saving all these neonates, our indications have changed for need for prolonged ventilatory support. And that is actually reflected in the sort of complications we used to see prior as compared to what we are seeing right now. So when you look at, whenever you've gotten the consult for doing a tracheostomy, there are a number of factors which, there are primarily 3 major complications which I'm trying to avoid while I'm doing the tracheostomy. One is, how do I save myself if the child has accidental decannulation and false passage? And how do we prevent wound breakdown? So all of my surgical strategies are essentially based on avoiding these 3 complications. So we'll just briefly go over the surgery. So I usually use a vertical incision. Before that, the positioning of the patient is really important. So have a generous shoulder roll. Most of these kids are chubby, so it's always essential to have a generous shoulder roll. I usually tape the baby's neck as well as shoulders down, so you actually form a neck. Most of these kids don't have a neck, and you literally have to make a neck. And you do a vertical incision. So I do a vertical incision. The thing with vertical and horizontal incision, eventually all those incisions look the same. With the vertical incision, you can extend it intraoperatively. There is a risk of injury to the anterior jugular veins if you're doing a horizontal incision. Again, that's not a big point, but for me, the vertical incision actually makes it easier for me to extend if if the incision needs to be extended. So after the vertical incision, the next step is essentially doing a generous lipectomy and remove all that baby fat between the skin and the tracheal wall and the strap muscles. And the reason we do that is so we avoid creating a massive dead space around the tracheostoma. And once we have removed the lipectomy, you've done a lipectomy, you essentially go in, find your strap muscles, open the midline, and then place your stay sutures. So stay sutures are absolutely essential in pediatric tracheostomy, and they're going to help you with avoiding if accidental decannulation were to happen, it makes it easier for anybody to put the trach back in. So we do through and through stay sutures. I usually go through the 2nd and the 4th tracheal ring, and we label them right and left. And after that, we make our vertical tracheotomy at the level of the 2nd and the 3rd tracheal ring. And again, the location depends upon why we are doing this. This is most commonly location if I'm doing for chronic ventilatory support. So once you've done the vertical tracheotomy, then comes stomal maturation. So I mature all my stomas, and the way it is essentially a vertical hemimattress suture. So you go through the skin, you come through the side wall of the trachea, the tracheotomy you've done, and you go back to the skin. So the skin essentially covers that stoma, and you achieve stomal maturation. I place two sutures superiorly and two sutures inferiorly. The key and the important point is your inferior sutures should not be that wide apart, because they are going to create a false passage inferiorly. So these sutures have to be placed a little bit closer to each other, so you don't create that false passage. We then place the tracheostomy tube, talking to an anesthesiologist, remove the ET tube, and eventually we do flexible tracheoscopy to evaluate the position of the trach and make sure it's at an appropriate level. And then essentially cover all the areas which you feel are going to have pressure issues with the tracheotomy. So I use duodenum, both above, where we are expecting some friction between the tracheostomy tube and the chin, duodenum below, and then we actually wrap the neck with something we call as Nepalex. So this essentially covers the whole area where we expect any sort of tissue damage or wound breakdown. A couple of things to mention. So this is our trach information sheet, and all these patients get a trach information sheet. This is actually taped to the bedside of the patient, and it gives in detail what cuff is it, what type of trach we have used, what deep the suction is going to be, when is the first trach change, and is the patient intubatable from above or below. And then we also place this algorithm for tracheostomy dislodgement. And again, this is placed on the bedside of the patient. So everybody, all the nurses are aware in case there is a trach dislodgement issue. Most of the patients after this go to the ICU. All the patients go to the ICU. I do my first trach change on day 5, and then patients are paralyzed for a couple of days, and then we start weaning off the paralytics. And during this period, all the nursing care matters exceptionally. So once we look at complications in pediatric tracheostomy, the complication rate is close to 10 to 58%, and the mortality rate, which has been quoted, is close to 0 to 3.6%. So the complications rate are pretty high, and this has gone really low as compared to what we were seeing in the 1970s, 80s, and 90s. And the way we classify the complications can be intraoperative, early postoperative, or late postoperative. So when we look at intraoperative complications, hemorrhage is an important complication. Pneumothorax, pneumomediastinum, recurrent laryngeal nerve paralysis, esophageal injury. You can lose the airway while you're doing the surgery, creation of a false passage, and then you can also have cardiac arrest and death. As far as early postoperative complication goes, the most important and the most severe is again hemorrhage, tracheal obstruction, accidental decannulation, false passaging, and subcutaneous emphysema. And in the late postoperative, you'll have stomal and granulation tissue, suprastomal granulation, tracheal stenosis, tracheomalacia, and fistulas in the form of tracheonominate fistula, tracheocutaneous fistula. So we're going to go broadly, little by little, on all these complications and how we can prevent them, number one, and how do we manage them. So once you look at hemorrhage, and hemorrhage can happen either intraoperatively, and if it happens intraoperatively, of course, you have to have a strict hemostasis. So you buzz everything, you cauterize every vessel you see. The second region where it can bleed is the thyroid isthmus. So I usually go through my thyroid isthmus. I don't ligate it. I just use a bipolar cautery and just go through the thyroid isthmus to get it off the trachea. And lastly, very rarely in pediatric cases, you can have an aberrant innominate. And if you have an aberrant innominate, you first of all try to do a high tracheostomy. The stoma is pretty high. And secondly, you try to create, there are two ways of dealing with an aberrant innominate and protecting the innominate from your tracheostomy. One is you can use an inferiorly based tracheal ring flap, which you use the third and the fourth tracheal ring. It's very difficult to do it in children, easier in adults. And secondly, you can use a local muscle flap, like a sternal hyoid flap, to cover the innominate, so it's not in direct pressure with the tracheostomy. If the hemorrhage happens post-operatively, then there are a couple of things which causes, more common causes is it could be just tracheitis, it could be a distal tip granulation tissue, and the most devastating or the most serious one is a tracheostomy fistula, which we are going to talk a little bit more in detail. So when you look at the tracheostomy fistula, the incidence of tracheostomy fistula is close to 0.2 to 4.5%. So, and this has actually gone reduced. The incidence has decreased over the last couple of decades. So the reason of the tracheostomy fistula is essentially the cuff of the tracheostomy tube is pretty much near the innominate artery, and it causes pressure necrosis and eventually resulting in the formation of the tracheostomy fistula. There are two mechanisms which have been proposed for this. One is the cuff, an overinflated cuff, directly causing necrosis of the anterior tracheal wall and eroding into the innominate. And the second is even the tip of the tracheostomy can cause it. So any cuff inflated more than 20 to 30 centimeters of water can actually result in tracheostomy fistula. The second mechanism of forming a tracheostomy fistula is if you have a low place tracheostomy, and that's why the position of your tracheostomy is very important, or you have a high riding innominate. And again, if you have a high riding innominate, those local muscle flaps to protect the innominate help in avoiding this. And secondly, always be cautious about the position of your tracheostomy tube. In this condition, it's not the cuff, it's actually the T-tube turn of the tracheostomy tube, which produces that pressure necrosis of the anterior tracheal wall, resulting in a tracheostomy fistula. So once we look in children with tracheostomy fistula, most of these kids have some underlying issues. They could be neurological or musculoskeletal. They might have spinal deformity, including scoliosis, cerebral palsy. And the way it presents, it may either present as a sentinel bleed, as we all know, or it may present as a major severe hemorrhage through the tracheostomy. Majority of these happen within the first month. However, they can present even later, all the way up till 2 years after the tracheostomy has been done. It is usually seen after 48 to 72 hours of doing a tracheostomy, and it can present as a sentinel bleed, which is a very small bleeding or acute bleeding. 50% of the patients will actually have a sentinel event before they actually have an acute bleed episode. So if you have a sentinel bleed or a bleeding through the tracheostomy, how do we approach that? The first step will be actually to do a tracheoscopy through the tracheostomy tube and look for any distal causes. Again, it's a sentinel bleed, it's not a major hemorrhage, and it has stopped. And then you externally examine for any signs of any causes of bleeding. The next step will be to do a CT angio, and what you're essentially looking at is a tissue plane between the tracheostomy as well as the innominate tree, and you want to see a nice plane between both of them, which means there is that is normal. But if you don't see any plane, essentially, and you're actually looking at an opening, and that means the patient has a tracheostomy fistula and needs to be taken to the operating room. The next step after CT angio, if you suspect a tracheostomy fistula in case of a sentinel bleed, will be direct operative visualization. And what you essentially do is you have a fiber optic bronchoscope loaded with an ET tube. You go in with that and you remove the tracheostomy tube, inspect the tracheal wall, and slide the ET tube, and eventually do a formal repair of the tracheostomy fistula. What happens if you actually have a massive hemorrhage? Then things change a little bit, because now the patient is actually bleeding. So you go to your ABCs of resuscitation. You do the most important component of this whole is local hemorrhage control, is how you're going to control the local bleeding from the tracheostomy fistula. You secure the airway, you do volume resuscitation, and then immediately consult cardiothoracic and transfer to the OR. So all these steps are going simultaneously, essentially. And there are two ways of doing local hemorrhage control. One is you overinflate the cup, and this actually is the simplest, easiest way of controlling the acute event. Number one, and then it works, to actually tamponade that innominate artery. So overinflate the cuff, use saline for this. Try to avoid using air so that you have a strong cuff pressure. If this doesn't work, then what you end up doing is what we call the O'Flay's maneuver, in which we essentially put a finger and compress the innominate against the sternum. The issue with this is it can sometimes be difficult to place that finger with a tracheostomy tube in, and you have to remove the tracheostomy tube in order to place the finger. So what you essentially end up doing is first intubating the patient from above with a cuffed endotracheal tube, and then removing the tracheostomy tube and then placing your finger and causing the tamponade of the innominate against the back wall of the sternum. The definitive management after this is to do a sternotomy, and then which can be extremely difficult just because you have your finger placed over there. So you have to be very cautious, and you need to be in good terms with your cardiothoracic surgeon, so he doesn't cut through your finger. So after the sternotomy has been done, the best way of managing this innominate fistula is to ligate the ends of the innominate. And during all this process, you ensure that the airway is secured. The thing with definitive management is ligation is one of the best ways of managing tracheostomy fistula. Endovascular stenting has also been proposed, but it's very limited, and just a couple of cases have been reported. Some people use reconstruction of the innominate artery. Again, that requires some skill as well as has a chance of rebleeding. You can ligate the innominate artery, and then it doesn't produce any limb ischemia, essentially, because there are a lot of collateral. So ligation of the innominate artery is one of the most common things we do for controlling this bleed definitively. The next thing which can happen during a tracheostomy is pneumothorax or pneumomediastinum, and again the incidence has decreased from 10% to 1 to 2%. And there are three mechanisms of developing pneumothorax during a tracheostomy. One is you can have direct injury to the pleura. The second is you can have air dissection through the deeper layer of the middle cervical fascia, which goes through the pneumothorax, and then pneumomediastinum and will cause pneumothorax. And thirdly, rupture of an alveolar plate. So a couple of things: direct injury to the pleura. Again, it's important you're strictly in the midline. You don't go laterally. Your patient is positioned properly. Your patient is secured properly to the bed. I usually get a chest X-ray in the room before the patient leaves the OR to make sure there's no signs, there's no pneumothorax, and get a clear X-ray. Clinical signs in bronchopulmonary dysplasia kids in which we are tracheing, you might feel the kid has a pneumothorax. However, once you do a chest X-ray, it might be normal. So a chest X-ray is usually done in the operating room before the patient leaves the OR. And then a pneumothorax is essentially managed like any other pneumothorax. You have to put chest tubes in. False passaging, again, a complication which can be avoided with good surgical technique, and two ways of avoiding a false passage is essentially a generous lipectomy, so remove all that brown baby fat from the skin to the trachea, and then stomal maturation. So, and there are different ways of stomal maturation. I do the vertical hemimatris incisions. Again, a couple of points in stomal maturation. I use vitral sutures for this. Get the skin over the stoma, so you form a covering of the stoma. Stomal maturation doesn't increase your chances of tracheocutaneous fistula. It has been shown to make it easier for placement of a tracheostomy tube. Since stomal maturation, I've reduced my first tracheostomy change from 7 days to 5 days, and some people even do the first tracheostomy change on day 3. So it's a really helpful maneuver. You just need a couple of minutes to do it. The only issue while you're doing this maneuver, it just adds to the time while the tracheostomy is open, and you might have some leak in the circuit. Otherwise, I think it's a great maneuver, stromal maturation. Accidental decannulation, again, this is a dreaded complication, and this is why we have our whole system in place for managing of a fresh tracheostomy. With accidental decannulation, you can have false passage and loss of airway. So what are the things we can do intraoperatively? Again, those stay sutures, which I described, are really helpful in pulling that tracheostomy tube up, and you can place the trach tube in easily. Stromal maturation makes it easier for placement of a tracheostomy tube. Doing a flexible tracheoscopy at the end to check the length of the tracheostomy tube, and then securing the tracheostomy tube nicely with Velcro ties, and making sure it's snugly fit rather than loose will be helpful. In the ICU, of course, adequate sedation and immobilization. You don't want to crashing kids. In our institution, all these kids are paralyzed for 2 to 3 days, and then we start weaning off the paralytic and still keeping them sedated. And there's a full sedation protocol for this. And lastly, nursing care. So you should have a trained nursing care, a bedside information kit, and a bedside information sheet, essentially to manage a complication of accidental decannulation. So it's a whole protocol which we have developed for our tracheostomy patients, and all major centers have a tracheostomy protocol, essentially to manage these fresh tracheostomies. So surgically, as well as the care they receive in the ICU, all contribute in avoiding this really deadly complication of accidental decannulation. Tube obstruction or mucus plugging, again, is an avoidable complication. You need to keep humidified air. Frequent suctioning, we do Q4 suctioning or as and when required. And nursing care, trained nurses we have a core group of nurses who take care of all these trach patients. Again, all these can be helpful if there is tracheal obstruction or in avoiding tracheal obstruction. Another avoidable complication is wound breakdown around the tracheostomy tube. And the cause of wound breakdown is essentially friction generated by the tracheostomy tube, or it could be the direct pressure from the tube. The sutures and the straps which are used to secure the tubes can also cause wound breakdown. Pediatric skin is pretty delicate, and the ventilatory circuits which are usually attached are pretty bulky, and they can have this drag effect on the tracheostomy tube, putting pressure on the inferior aspect. And as well as the moisture from saliva and respiratory secretions can all form a very nice media for bacteria to grow and eventually lead to wound breakdown. So you really want to cover all these vulnerable areas in a child. Essentially, the superior part, the lateral flanges, as well as the inferior portion, needs to be covered with something which can absorb moisture as well as prevent direct contact of the tracheostomy tube. And there are various materials available. Pressure injury, you will have some sort of pressure injury. Stage 1 is usually seen in most of the tracheostomies, but stage 3 and stage 4 pressure injuries need to be avoided at any cost. A few of these, this is an infrastomal massive ulcer, again, showing the fact like this is essentially pushing on the inferior aspect of the tracheostomy, of the stoma. And then the second vulnerable area is just below the lateral aspect, where you have the lateral flange. Again, these pictures have been taken from the internet. These are not mine. So how do you actually prevent and manage these? So one of the things to do is to have appropriate protection for vulnerable areas. Second is you have to keep the wound bed dry. I use the soft tracheostomy ties. We don't use the twill ties or the cotton ties because they get very they can develop secretions. Secretions can get dried up, and you have cut through injuries where there have been reports of the ties actually cutting through the carotids as well. So so soft Velcro ties are great. Extended tracheostomy tubes or the flex-10 tubes are also helpful in avoiding injury because they don't rub against the superior and the inferior aspect of the baby. And one of the things which we can do is essentially cover that area. And there are so many things which are available in our market. I'm pretty sure in India there might be something different. But I use the Duoderm and the Maple X. Duoderm is a hydrocolloid. Maple X is a foam dressing, which is a very good, absorbs moisture really nicely. And these are our standard Velcro ties which we use. So covering this baby nicely and leaving no area is a great way of preventing wound breakdown. Granulation tissue, and again, since it's a foreign body in the airway, it's going to produce granulation tissue. You have friction from the tube rubbing against the tracheal mucosa, and you can have peristomal, suprastomal, or distal tracheal granulation. Peristomal granulation, pretty common, very easy to manage. You can cauterize it with silver nitrate. You can electrically cauterize it. You can excise this granulation tissue. You can use a steroid ointment. So pretty easy to manage. The suprastomal, we are going to discuss a little bit further. Again, a very common complication. It's so common, it's not even considered a complication. Most of the pediatric trachs end up having some sort of a suprastomal granulation. And then lastly, distal tracheal granulations, which can be a little bit tricky to manage. The tip of the tracheostomy tube is rubbing against the back wall, and then you form a granulation tissue. And a couple of things which you can do is you can laser excise these. My go-to tool for this is laser, essentially. And you can laser it and put a longer tracheostomy tube so that you bypass this granulation tissue. You can do cold steel debridement of this lesion. Of course, that will be associated with some bleeding. The tricky part of doing distal tracheal, attempting to do distal tracheal granuloma excision is in children who are tracheostomized but are not, but you can't do a bronchoscopy or laryngoscopy if they have micrognathia or retrognathia. And I still remember a patient coming to me with severely obstructing distal tracheal granulation tissue way down. And the kid was a ear vein sequence baby, and we could not actually do a DL. So we ended up doing a fiber optic laser excision of this granulation tissue. So just something to keep in back of your mind. Flexible laser is a great option for these sort of lesions. As far as suprastomal granulation tissue, we all have our tips and techniques of doing it. There are like so many instruments available to do suprastomal granulation excision. Nothing is better one or the other. It's just what achieves the goal. Again, it's pretty common. Minor supraglottic suprastomal granuloma, you don't need to treat. But if it's a big granuloma which is completely obstructing, causing bleeding, dysphonia, aphonia, or when the child is ready to get decannulated, then you will proceed with removal of this granuloma. And there are various techniques. You can do an endoscopic technique, or you can do an open technique. And again, you have so many instruments available. Nothing is better than the other as long as you get the job done. So one of the common techniques you'll see is hook and cut. So you will place a hook through the tracheostomy stoma, evert the stoma, and then you essentially use a tenotomy scissors, or you can use bipolar to cauterize and remove the granuloma. The second you will see is a sphenoid punch. You place the sphenoid punch into the stoma, or you can also use the frontal ostia punch, which is a little bit curved and actually gives you more angulation. And somebody is doing a bronchoscopy from above, and you can visualize what you're removing. And lastly, you have your optical forceps in which you can pass and do a cold steel excision of the granulomas. In my experience, the hook and cut and the sphenoid punch work great if it's a small granuloma in a bigger child. It's very hard if you have a 3 or a 3.5 tracheostomy tube. placed in, and a massive suprastomal granuloma to actually get decent view to do a hook and cut or a sphenoid punch. The other thing to use is laser. Again, I love using lasers. So you can use a laser to excise a suprastomal granuloma. Works pretty well in any age group. You essentially just use, and I like using laser in the ultra pulse mode, minimal collateral damage, minimal, you achieve your hemostasis as well. And this is the post-operative suprastomal granuloma. People have used microdebrider. The issue with microdebrider is it's hard to place in smaller babies. You can use coablation. Again, it's hard to place in small babies. You just don't have that much of space. Flexible laser works pretty well. One of the things is open resection. And again, I believe it's a great technique. It's pretty simple. What essentially, it is essentially an excellent technique to do an open resection of a granuloma in smaller babies. So this is a small child, has a 3.5 tracheostomy tube, and it has a massive, completely obstructing granuloma. It's such a simple technique. You do your, you open up the trachea by vertical incision. You can see the granuloma. I usually put a hemostat in. And just evert that granuloma and use a bipolar or a beaver blade essentially to remove that massive granuloma. You stitch up the trachea, and that's pretty much it. So I usually do this more often in smaller children in which it's very hard to instrument the airway, or in kids in which you cannot do a direct laryngoscopy or bronchoscopy to them. Suprastomal collapse, again, we commonly see it, especially since we have been starting using those flex stent and heavier tubes, which put greater pressure on the anterior tracheal wall. A lot of inward collapse of the anterior tracheal wall. Usually we say it's more than 75%. It's severe and moderate if it's 50 to 75%. And if it's a mild suprastomal collapse, the kid is ready to get decannulated. Usually don't do much about it. But however, you have to address this if it becomes a problem and the child cannot be decannulated. And again, there are a lot of papers published on managing suprastomal collapse. You can do internal stenting. Some people like to intubate the child for 2 to 3 days. Or you can do external stents like a suprastomal stent or an expandable, cause their own set of problems. You can have more granulation tissue. You can form stenosis related to the stent. External splinting has also been described. Pass a stitch through the collapsed part of the trachea and hook it up to the strap muscles. There have been descriptions of bioabsorbable mini plates, which are used to support the anterior tracheal wall. Or you can do an anterior costal cartilage LTR, which essentially is a sort of external splinting with the costal cartilage. Some people have described simple transverse closures. You can just then join the collapsed anterior wall with the solid and stable lower wall. There's been a paper published, the collapse was corrected. I personally feel it's we all are very facile in doing anterior costal cartilage grafts, so that's actually my go-to technique for all these cases. I try to do these specifically single stage because this is usually the last step in their decannulation process, and you can just put a simple graft on top of that collapse. If you recommend it to do a single stage, we can have doing a double stage thing. A couple of more things related with tracheostomy. One is and you can have an decannulation process.
Can you mute all the mics? It's interfering with this.
Yeah, are muted. There's one. I don't know. This one is good.
Okay. Yeah, so this is something which needs to be addressed prior to decannulation. And when you look at the A-frame deformity, again, there are a couple of ways of addressing it. You can do a simple, straightforward anterior costal cartilage graft just to augment the anterior part. And this is something this is a simple A-frame deformity. We've just done an anterior costal cartilage. If you have a more severe A-frame, technique will come into place, either a simple tracheal resection or a slight tracheoplasty. But again, this you will tend to see this. This picture is of a patient who had an anterior posterior graft, so it's not exclusively trach related. This A-frame deformity after an amputation next week. So, so resective as well as augmentative techniques are great for managing an A-frame deformity. Lastly is tracheocutaneous fistula. A common complication and incidence has been reported from close to 3 to 30%. One of the factors which affects the formation of tracheocutaneous fistula is duration of the tracheostomy. When do you repair tracheocutaneous fistula? I wait for at least before we go ahead do a tracheocutaneous fistula repair. And again, there are a couple of ways of doing it. One is you essentially excise the tracheocutaneous fistula tract and close it. And the other is you just excise the tract and just let it heal secondarily. You don't close the tracheocutaneous fistula. So as far as the closure goes, you excise the fistulous tract down to the trachea. You close the trachea with a 4PDS suture. And once the wound is closed, the patient is sent to the ICU. Some people like to intubate them for a day or so just for healing to take place. Some people extubate them on the table. Again, various ways of doing it. If it's a large tracheocutaneous fistula, you can use a cartilage graft. I've done it with conchal cartilage grafts. If it's even a bigger defect in a bigger child, then you can use a anterior costal cartilage graft. Again, simple techniques to close them. Recently, a trend has been to do more of these without primary closure, and the reason is if you close it primarily, there is a risk of pneumothorax, and there has been some major complications where the child had an undetected pneumothorax and had a bad outcome after tracheocutaneous fistula. With reports of that, and as such, recently more centers have been doing a secondary intention tracheocutaneous fistula. So essentially, you excise the tract, you don't close the trachea, you don't close the wound, and let it heal by secondary intention. And this is my go-to technique now. And previously, I used to think it's going to look horrible, but it actually doesn't look that bad. It is cosmetically as appealing as if you primarily close them. So before I conclude, I just wanted to go through this tracheostomy safety initiative, which is involved in the care of trach children. It's a whole system which has to be in place so you can actually manage your tracheostomies in a better way. And it's having the correct surgical technique, excellent protocols in the ICU for sedation. The equipment should be great in the ICU. So if you have an accidental decannulation, the training of the staff has to be standardized in which so one of the things we have is this tracheostomy safety initiative, and we have various components of this initiative. One is we had a tracheostomy consensus. So you will read consensus statements by some societies, but eventually what matters is what consensus you have in your institution. So, so it's highly encouraged to have a consensus in your institution with your NICU, your PICU staff, your nursing staff, what their nurses are, and then you can identify what areas we need to work on as far as tracheostomy goes. We have a difficult airway service where we have all these patients who are difficult airways or have a tracheostomy are labeled as difficult airway. And they come through a multidisciplinary PEDS airway program once they are actually discharged from the hospital. Have some protocols set for your airway reconstructive procedures as well as for tracheostomies. Sedation protocols is exceptionally important for managing these children. So all of us should be on the same page as far as how we are going to manage this child post-operatively. From a patient safety perspective is to have each one of our floors, is NICU and the PICU, to have their own airway cards, and everybody should be aware, all the residents, where all these instrumentations are placed. So in conclusion is tracheostomy is associated with high morbidity, and you should have a meticulous surgical technique to avoid any complications. A multidisciplinary team approach is required for management of these patients, and I think each one of us should have their own consensuses in their hospital. Thank you.
For that comprehensive problems of tracheostomy, problems. Dr. Kishore Sandu is from the University of Lausanne, from a pioneering center, a pioneering surgeon, internationally renowned. And Kishore, are you there?
Yeah.
Yeah. Kishore, we thought we'll start with your talk and then do the discussion with the panel.
Sure.
Yeah.
I think Sohit needs to stop sharing.
Yeah, your screen is still on.
Kishore sir, you can share your screen. That will automatically.
All right.
Yeah.
Okay. So do you see it now?
Yeah. Share now. Share.
All right. Do you hear me?
Yeah, we can hear you.
All right. Thank you so very much for the invitation. But Raman and Prahlad, a big thank you to you to put up such a wonderful show and to have such a kind of a platform. It's really wonderful to be here on this particular platform and to talk to all of you. I was just actually going through my messages, and someone actually texted me that talk very quickly because the IPL is going to start in the next couple of minutes. So I'll try to keep it as short as possible and try and share a couple of things as far as laser injuries are concerned. All right.
Yeah, go ahead, please.
Yeah. So as regards laser-induced complications are concerned, remember that you have three issues in them. One, these complications could be operator-related. So typically, these are related to what laser you're using. What is your indication? In which patient are you using? Is it a very, very small kid of 10 days old? Or is it a 10-year-old? Or is it really an adult like a 50 or a 60-year-old adult? Training is extremely critical. Then you have anesthesia related, of course, again, the technique and again, the training in anesthesia.
Yeah. We don't have your
screen is not showing.
You have to share your screen.
Yeah, I have already shared my screen. Hang on, let me.
It's not there yet.
Maybe reshare.
Yeah, 1 second, but now I can't go out.
You can go to new share. Yeah.
So is this okay now?
No, not yet.
1 second. So what about it now? Sorry?
Still no.
1 second. Then I think I have to really go out because I think there's some problem with. So this is what you see, is it? So.
Yeah, we don't have just blank screen.
Yeah, we got you to share the.
What about it? What about now?
We have your video. You have to go to new share or share screen again and share your PowerPoint again.
Okay, just 1 second. New share.
Yeah, it's coming.
Is it better?
Yeah, got it.
All right,
Good.
so I need to start again. So let me sort of, very quickly sort of summarize the first slide. And what I was saying is that laser-induced complications are basically related to three basic aspects. You have operator-related complications, and this is related to the choice of the laser. So what is the indication for using the laser? In which is this patient? What is his age? Are we using the laser in a 2-day-old kid or a 2-year-old kid or a 20-year-old man? Training is critical. Then you have anesthesia-related complications. And again, technique is very, very crucial. And even more important is the training. And do not forget that, there is a device, there is a tool, and the quality and the device maintenance every month for the entire year or years is critical as well. And remember, there is a training that is involved in these kind of device-related issues as well. So you have a laser technician and you have nurses, and there you have the common part in all these three issues is the training. Plus, remember the communication. So you have the surgeon who needs to communicate with his anesthesiologist, and then he needs to also tell the technician, or, as we say that, there is someone in the OR who's helping put the laser in the right place, the nurses. So eventually, it's the communication between all these three actors so as to avoid any kind of problems. And if we have faltered in any of these 3, 4, 5 areas, remember, there are two basic aspects that happen. You have an immediate effect that would mean that you either abandon the surgery or you have to unfortunately stop and do an incomplete job, or you end up having a laser fire. And the late effects are that basically because you have used the laser in an incorrect way, you will end up having irreversible tissue damage with disastrous sequelae. We in the CHUV, or the University of Lausanne Hospital, is a tertiary setup, and the airway unit or the sector is the quaternary facility. We have been using lasers over the last 25, 26 years. We have done a lot of operations. Remember, we are not just a pediatric hospital. We are dealing with pediatric as well as adults. We manage malignant lesions. We deal with congenital lesions, acquired benign lesions, iatrogenic lesions, caustic lesions, etc. As far as the sites are concerned, we are into airway, so right from the nose till the bronchi, esophagus, and this is what in fact my unit deals with, and we will concentrate on the aerodigestive tract. And of course, there are diverse delivery systems that we use in our unit. This is an article which I think is extremely interesting, written by Sattelov very recently in the otolaryngology head and neck surgery. And he actually discusses the adverse events and device malfunctions which are associated with a variety of laser surgeries. And what is important is that it emphasizes on the shortcomings in the current reporting. I will try to sort of, speak a little bit more about these problems. So this is actually based on the US FDA database. And what Robert has done is that he has actually divided these complications that are adverse to the patient. Kindly note the percentage that is involved in this. So those where the patients are involved, it's almost over 42%. And this is typically related to a dislodgement of a laser fiber. Now imagine that the laser fiber which is dislodged, but we are causing the damage to the patient because of perhaps some kind of technical problem. Adverse event to the operator. Now this was actually the technician did not put in the filter in the microscope. So it was an unfiltered laser that caused corneal burns in the surgeon. Again, who's to be blamed? It is the team. And then you have a large group of complications which are device malfunction related. Fiber breaks, flares. These are the two main reasons which cause airway fire. And in fact, the rest again are disastrous situations, conditions which actually are causing complications in our laser procedures. We have been using lasers for a long time, and this particular presentation is based from 2003 up till 20. We have had about 8 catastrophic airway bleeding, and these are basically related to tumor laser surgery in adults. We never had to abandon the surgery. We never have had a laser fire. There has been, fortunately, no death related to the procedure during the procedure. And as far as late complications are concerned, we have never have had circumferential symptomatic aerodigestive stenosis. Let's try to go to the basics. If we see a complete sort of group of these lasers that we're using currently, you have some lasers which either vaporize, cut, or coagulate. And remember, what are the laser tissue interactions that we are looking for finally to treat the patient, which are really, really critical. So if we are looking to vaporize and cut a tissue, ideal would be a CO2, argon, or KTP. And if we are thinking of coagulating a tissue, basically you need to have the lower wavelengths getting involved, typically argon, blue lasers, Nd:YAG, diode lasers. This is a chart which everyone is aware of, but basically what we are trying to do is we're trying to compare the wavelength of the lasers and the tissue absorption. So all the low sort of wavelength lasers, typically argon, KTP, diode, blue lasers, they will be actually in coagulation, so they are more absorbed in the hemoglobin. Whereas the CO2 or high range wavelengths, typically the CO2 are basically water absorbed, and they will be used precisely to only cut a tissue because they are more of water absorption. Have a look at this particular picture. So we are using for a very long laryngotracheal cleft the ultra pulse CO2 laser. We have incised the cleft. There is no charring. Remember, charring is scarring. And then finally, in fact, we sort of repair the cleft by actually a 2-layer closure. Again, what we are trying to say is that remember, what is the laser that you're using, what is the indication, and what is the end result of your using the laser that you want to achieve. Now here is another patient. You have a 5-year-old boy who presents to you with a huge tracheal mass with respiratory distress. Do you want to just cut this off? Probably not only a good idea, but what you want is, apart from incising it, you want some amount of vascularity or a coagulation effect. And that's where, in fact, you want to use the KTP. However, have a look at the situation here. You are at a distance, you're using a fiber, and there is charring. You are trying to actually denaturate the proteins. You are trying to achieve a vascular control. KTP is a good option in a situation like this. Remember, when you're using all these fancy gadgets, you need to realize what happens outside the trachea. You have a lot of mediastinal blood vessels that need to be well controlled. And this is the end result. This is actually coming from an adult article. There are these 4 basic areas that any laser user or any younger colleague listening to this particular topic must remember, that you have to look for absorption of the laser, scatter, transmission, and reflection. Look at this picture. These are chiral mets, and then lasers have been used that give actually 2 different effects. If you see here, this is black carbonization or charring, and here, in fact, this is blanching. Remember, protein denaturation happens at 65 degrees. Tissue desiccation that leads to shrinkage is caused at 100 degrees. And then anything that is more than 100 degrees actually goes into this blackening effect. There is vaporization of the interstitial and intracellular water, which in turn gives rapid rise in the tissue volume. And sometimes people who have used the laser would have seen something called as the popcorn effect or scattering effect, meaning you have these sort of funny sounds, noises create something bursting. Now, this is related to the rapid rise of interstitial fluids. Why I'm telling you all this is because you must realize what is going to cause complications if you're not aware of them. There are two basic points that you need to realize. One is a super pulse and ultra pulse. A super pulse, which is the blue sort of conical part, remember that it is basically below the ablation threshold. Whereas, and this is in fact a greater momentary tissue impact causes a more thermal diffusion. Whereas if you look at the ultra pulse, which are these rectangular sort of blocks, they're usually above the ablation threshold, and this actually causes lower thermal diffusion. It is important for us to realize what is a pulsed laser, and are we looking at a chopped pulse or are we looking at an ultra pulse? Remember, the chopped pulse is almost 7 times longer than the ultra pulse. So anything that is going to give more energy is going to transfer more thermal heat, and that is going to cause collateral damage. So what are the goals of laser surgery in a child? You want, of course, minimal tissue damage. How can you do it? Stop the laser transmission. Select a laser with a wavelength with a short absorption length, typically a CO2 laser. Stop the conduction. So remember to use a pulse laser that allows gradual progressive vaporization. At the same time, in fact, it allows cooling of the tissues. And focused beam is something that delivers high energy density, and this is going to cause more an effect of cutting or an ablation, but under a precise scalpel kind of a dissection. Have a look at this particular tissue laser effect. So we're using pork meat. This is a CO2 laser, and this is an ND-YAG laser. So this is going to cause a much focused kind of a damage. But the same thing, if you are going to see, in fact, in the cross section, have a look at the CO2, which actually is going to go deep down into the meat, but which is going to actually not cause too much of a lateral damage. As against that, if you compare that with an ND-YAG, the same situation is slightly different. This is ultra pulse. This is a continuous mode, 3 watts chopped mode, and this is a 3 watt continuous mode. Again, point I'm trying to make is that it depends upon which pulse mode you're using. Are you using an ultra pulse or are you using a continuous wave at the same 3 watts parameters? So now we come down to how one avoids a laser-induced complication. So this starts with selecting the correct laser, and that selection depends upon what laser you have and what parameters you choose on your tissues. Please remember, you must be aware not only how to use the laser, but of the laser tissue interactions and these effects. And both of them depend upon the indications and the age of the patient. In the next 2 slides, I'd like to sort of, place in front of you what are the lasers which are problem lasers, which are based on the choice of the device for a particular indication. So the block in blue is basically an indication, for example, a juvenile onset papillomatosis. So a problem laser are all those lasers which are going to be low wavelength, diodes, blues. They are going to cause a lot of collateral damage. Try to avoid them. Now, in the other sort of block is what I would like to sort of share with you. What would be an ideal choice for that particular indication. So if you have a papillomatosis patient, I would typically use a microdebrider. If I have to cut the tissue, I would typically use a CO2 ultrapulse. If you're looking at tracheal tumors, bronchial stenosis, we are going now into the mediastinum. CO2 is not a good laser. Why? Because it is going to have an air driving it. You want to cool down the tissues. So remember, anything beyond the carina, and if air is going to go into open vessels, they will cause air embolism. Plus, you are very close to major vessels. So that's where, in fact, you want something which is going to coagulate the particular tissue. A KTP diode laser is a good instrument to have for tracheal tumors. Bronchial stenosis, ideal would be monopolar knife or a cold steel instrument, because the bronchial, the mainstem bronchi itself, the diameter is much smaller. So remember, think of the collateral damage, which in turn is going to give you the final result. And then a word about coablation in upper airway. I would never use a coablation in a pharyngeal stenosis, which is circumferential. As against that, what I would achieve to do is to cut the stenosis, to raise advancement mucosal flaps, and end to have a fully mucosalized upper airway. That is what is going to give you the right result. Let's talk of age. Now we're looking at very, very small kids, neonates, infants, very small children, small airways. Do not be very fancy, because this is going to cause an effect on smaller airways. So again, the same story, the blue, and then you have an ideal choice, green options in front of you. So let's say, remember, we're looking at very small kids. So if you have an incipient stenosis, any laser is going to be a problem in a small airway. I would go to cold steel. Of course, if you have subglottic cysts, and typically circumferential subglottic cysts, in those cases, I would use the laser, but the idea being marsupialization, and I would stage the procedure. I would not go at the same time touching the both sides. However, every case will be taken case by case. Rhinopharyngeal stenosis, again, the same problem with coablation. My option would be to incise, and I would be very happy to have a mucosalized upper airway. A word about anesthesia related or operative techniques. So anesthesia, typically we are looking at the source of oxygenation. So there are various ways and techniques of preventing a laser problem related to oxygenation. So you have spontaneous with local anesthesia, successive apnea, jets, thrives, etc., etc. I think more important than all that is what is your working distance and the parameters, and what kind of laser you're using. A lot of times, if we're using fiber lasers, remember, you are going to char the tissues, and oxygen in presence of the charred tissue is also going to inflame and be combustible. So think about these problems. And of course, you have incorrect surgical techniques. Overzealous use of the laser and safety protocols that have not been followed. If we're looking at the incorrect technique itself, we should be looking again and again at, are we using the right laser? Are we respecting the surgical fields? If you're not going to respect the anterior and the posterior commissure, be ready for Siddiqui in these particular areas. Circumferential airway trauma, whether it is in the glottis, subglottis, trachea, bronchi, will come with problems. Non-optimal mucosal cover and cartilage exposure is something which you need to realize. If you have cartilage which is exposed, air which is being going up and down the airways is a source of infection. So that itself is going to desiccate the mucosa even further. Infection is going to get in. You will have perichondritis, you will go into a cicatricial stenosis process. Overzealous use is something that you should try to avoid. I share with you a 5-week-old child who was referred to us from Germany with a problem after laryngomalacia treatment. So this is a supraglottic stenosis following overzealous use of the laser. And in fact, you can see that unfortunately, we see that the area epiglottic folds have now become so small and short that they have pulled the epiglottis inwards, and they have transformed maybe a severe laryngomalacia, but into a even severe supraglottic stenosis. So this is the way I would treat it. I take the laser, I take an T-shaped incision. Remember, this is under spontaneous breathing and sometimes with a backup endotracheal intubation. This is an ultra-pulse CO2 laser, luminous, duo, and we create a T-shaped incision in the stenosed area epiglottic fold. We would do the same thing. Let me just go a little fast forward on that. We would do the same thing on the other side, and the whole objective being that we create localized mucosal flaps. And then we would sew down these mucosal flaps laterally. And whilst we are going to do that, before we're going to do that, we will also do a correction of the epiglottis. So typically here, the ultra-pulse parameters will change. We will use a continuous wave mode, and we will fix the epiglottis with the base of tongue using a Listenberger's needle carrier. We will further go ahead and put in sutures for the mucosal flaps which were created so as to achieve a full mucosalization of this particular patient. And eventually, the patient did really well. This is a 3.5-year-old boy who underwent an adenotonsillectomy and landed with a severe rhinopharyngeal stenosis. You cannot use coablation here. You have to go, and your final objective is going to be a mucosalized airway. So eventually what we did is we excised the stenosis, we raised local flaps, we sutured the local flaps in place, and that actually is the result. Can we, do you hear me? Hello?
Prahlad, can you mute? Some mics are unmuted, I think. You can just mute that? Go ahead.
Right. So this is a 4-year-old girl with a saccular cyst. I'm sure you have all seen this. But just to sort of share with you the way we would approach from the anesthesia point of view, we do a transtracheal jet. And once the transtracheal jet is in place, we create a possibility to have an adequate egress of the ventilatory gases. And then, of course, use the laser, and finally, you have an end result, which I'm sure, you guys must have had the same cases as well. Whole objective being to share, a transglottic jet in a situation of quite a difficult problem. Again, a transglottic jet for a bilateral vocal cord paralysis. We try to create a mucosa. We do an arytenoid resection. And again, the whole objective being that I want the larynx or the airway to be fully mucosalized. Otherwise, that is going to granulate. That is going to give an exposure of the cartilage, which in turn is going to lead to a recurrence. This is a 5-year-old boy with caustic injury flying from Gabon in Africa. And when he came to us, he was in a bad shape. He had severe respiratory distress. And in fact, what you can see here is epiglottis being completely tethered to the posterior pharyngeal wall. The vocal cords were fine, but he had a very severe oropharyngeal stenosis plus the esophageal stenosis. So the way we actually approach this is, in emergency situation, we actually used the laser to only open up so that he has a good airway till the definitive surgery is planned. And finally, what we did is we excised the tissues, we removed the esophagus, we raised the colon, And finally, we had the left piriform sinus, which was sutured with the colon to end up having a good result. So to conclude, remember that one aspect is to know about the laser and its complications, and the other side is how to avoid them. So if you have to avoid them, remember the choice of the laser is critical. It depends on indications, it depends on age, and don't forget the training for all the actors. It's not just the anesthesiologist, not only the operator, but even the technicians who are helping you, the nurses who are helping you in the operation. Laser tissue interactions. Remember, if you are doing a dedicated airway aerodigestive work, you cannot be contented using just one laser. You will require multiple lasers, multiple equipments, and I do completely understand that it is expensive. But unfortunately, this is the way these procedures are, these conditions are. It is costly, but you will have to realize that the advantages are far better as against using one laser that is going to give you other problems. Safety protocols is something which applies to all of us, and of course, as the British would say, and everyone is aware of this aphorism, that a fool with a tool is going to remain still a fool. The problem is that more dangerous the tool, more dangerous is the fool. So if you have the laser, which is going to be the tool that is going to be used by, unfortunately, a team which is not going to be very well trained, they are going to face problems. So in conclusion, try to realize it's not the laser. It's about all of us who are actually using these various tools and devices finally to achieve a particular result, which is based on our choices and our selection of cases. I thank you again for a patient listening. And again, thank you very much to Prahlad and to Raman and all my colleagues, panelists, and experts who are there in this particular webinar. I thank them as well for their time and their participation. Thank you so very much.
Thank you so much, Kishore. As usual, one of those excellent lectures covering everything. We'll quickly just have a small discussion. And any questions to Dr. Sohit regarding his lecture on the complications of tracheostomy? I think a lot of questions and answers. Yeah. Okay. Any comments from, is Dr. Ashwath there and Dr.
Yes, we are there, sir.
Yeah. Dr. Ashwath and Dr. Pratap, just wanted to know regarding what kind of, for example, when you refer a patient for a tracheostomy, what are the criterion you're looking for? What is the cutoff point when you consider a tracheostomy? Can Ashwath go in first?
Yeah, so I think it depends on the child's condition and whether it is something, it could be as simple as a acute or a short-term tracheostomy for securing the airway. It could be a child who's got a problem with the airway, like it can be a trauma causing an obstruction or a tear to the airway where we need to secure the airway. Or it can be someone who we can't intubate kind of situation or ventilate. These are the acute conditions we may look for tracheostomy. And the midterms where we look for is, it depends on the, usually the places where you practice as well. I've seen in few units, and each unit has got a different threshold for children who are on ventilator dependent. And in pediatrics, generally you can say, we try to have a higher threshold to put a child on tracheostomy for kind of a respiratory failure or a ARDS child than compared to the adult populations. And to some extent, we may even take a chance of having a trial of extubation during a second week and then see if this child is really going to need a much more longer dependence of ventilation, then we would try to go for a tracheostomy. So that could be the other common conditions we face. And the precious airway children, I kind of already mentioned, or those who are having facial malformations, where we will need a secured airway as a long term, is one other condition. And chronic children with severe trauma, or someone who is having not able to protect the airway on a day-to-day issue, could be another common condition where we'll have to put a tracheostomy in. So as the list keeps on going, but in short, I think the commonest would be is acute would be where we have an emergency situation, and then it will be where somewhere in the 2nd to 3rd week of our intubated children, and then it will be the chronic children where they will need it for around long-term tracheostomy cases.
Right. Thank you. And what about Pratap, regarding the neonatal age group? I mean, there might be situations where you refer the patient to for an upper airway examination. Say, I mean, is there a number of extubation failures that you have which make you suspect a long-term features?
Yes, sir. I think we've fortunately we've not had many of those cases, but then in those cases who needed some sort of airway help, I always refer to anyway. Thank you so much for looking after those babies. So some of the examples of those were subglottic stenosis is one of them. One of them had a cleft. One of them had a big nasopharyngeal, the mass, which was just going and sitting on top of the epiglottis and then not allowing this baby to breathe. But in terms of needing tracheostomy, especially, I think I've had a couple of chances, couple of instances where we needed that. But unfortunately, the parents don't like it, and they because the prognosis was not so good. This is a case where a baby was born without crying and birth asphyxia, and then we did total body cooling for that baby, which is one of the therapies for birth asphyxia. And then the baby started doing really well neurologically, especially crying and all those things. And then we extubated the baby. The baby, in fact, within few seconds, started having complete desaturations and apnea, not breathing at all. And then we had to reintubate. This happened 3 times, basically, because we were not, we were thinking everything is very good, hunky-dory. But at the end of the day, we realized, the baby is actually paralyzed completely, neck down. And when we did repeat an MRI with including the neck, we realized that there's complete, transection, not complete, it's partial transection of the spinal cord at the level of the C1 and C2. So this is one of the birth-related injury, which is very rare, and we, in fact, reported that. And this is the one case where we knew cooling would have helped that baby as well in terms of the spinal cord injury. And we wanted to see for at least about 3 months, and we were planning to refer that for a tracheostomy. Unfortunately, patients, disagreed, and in India, you know how it works, so we have to listen to them. Secondly, there was a case where it was very interesting. We did a bedside, PDA ligation, and during this, there was an accident, phrenic nerve injury, and then resulting in diaphragmatic palsy. And we knew from straight away that we need to ventilate this baby for at least 6 to 8 weeks in order for the diaphragm to improve. And again, with lack of money and everything else, the parents, denied going to the, not denied, they said no for the tracheostomy. Fortunately for us, after 6 weeks of ventilation, the baby recovered, and actually that baby is doing well. So the need for tracheostomy, to be really, really honest, in India is a bit less coming from the neonatal world as opposed to for a child who's actually admitted and needing prolonged ventilation. Thank you.
Yeah, thank you. And now regarding the questions on the laser, any comments, Deepak or Karthik? Anything you want to add on the use of lasers? Is Karthik there? Deepak, any comments? Okay, can you quickly put that slide on the program that we have, the international webinar? If you can just put it back for a second. Prahlad? Yeah, so is Deepak around? So C Surgeries, headed by Deepak, and the other group is organizing this International Pediatric Airway Symposium. And the dates are given here, so kindly register. People who have registered for our conference, which was supposed to have been scheduled in March 22nd, which has been postponed. We thought we'll do it after 3 months, 6 months. We don't know when COVID is going to end. But anybody who's registered for that, you can get in touch with us. We'll get you registered for this. And the modalities we will discuss with you, but you should let us know about it. Whoever's interested in this particular program, which is going to be a wonderful program because the best airway surgeons in the world are giving talks, and the subjects are varied. I don't want to waste time now. You can go through the website and then check it out. So Dr. Moghira is asking a question. What is your preference for the laser safe tubes? Which type? Kishore?
Well, we don't use laser safe tubes. We use only spontaneous breathing and successive apnea. So in children, laser safe tubes, unfortunately, the sizes are too big. And in children, we don't use laser tubes. We use only jet ventilation. We are not still using Thrive in children. Yeah, I mean, laser tubes, honestly, last 10 years, I've never used them.
That's reassuring because we always feel the absence of it, but we don't have access to it. So we've been managing with that. And of course, with a lot of help from our anesthetist friends, is Jesh here, mention it, but then Kishore is around here. They've got a lot of laser experience. We have relatively less, but there are a lot of people who are using laser in the hinterland and landing up in trouble because of, some anesthesia-related issues. So can you just outline how you manage the cases?
First of all, thank you, Raman, for inviting me for this webinar. Basically, what I feel is all the talks were excellent. I just wanted to, before I go into the laser,
Intubation?
I would like to wish to tell you about a small little tip that we use in preventing intubation injuries, iatrogenic injuries. Most of the injuries occur when you do emergency intubation, where you do not use relaxant, and the child is struggling, and there's a main thing with, you're not sure the airway and you don't want to paralyze the child, whether you want to intubate or whether you'll be able to ventilate. So this is the stage where if in a elective surgery where I can even relax and intubate, there is no issue of traumatizing so much as compared to intubating a neonate premature where we do not paralyze. There I usually use a small little local spray. You just oxygenate the child, just gently spray the supraglottic area and near the glottic area with the dosage of the local anesthetic in mind. And then you, after you again oxygenate and you just intubate, the intubation becomes a lot more smoother than doing. So, and introduction of radioscope, as it was mentioned by Karthik, we have to be very gentle in doing that with the vision of the scope. And then we have to go in subsequently with, choosing the right size tube. We do use micro cuff tubes, and that really reduces the size of tube at the glottic aperture, and of course the cuff pressure measurement. This is, and gentle handling, and never force anything into it. And other tip that I use is in a very small premature or smaller babies, if there is a doubtful anatomy or difficulty in intubation, I usually use, instead of using stillets which are hard and can traumatize, we use a guide wire, which is much less traumatic. And then once you are into that, under vision, we put the tube. So that again reduces this railroading always reduces the trauma to the glottis and supraglottic area. So that is the thing I wanted to tell about the iatrogenic intubation problem. The other thing that is about laser, as Kishore said, if in children, we do not use laser compatible tubes because they are bigger in size, and again, it's very expensive to use these things. So we have to make sure our oxygen concentration is less than 30%. So this is what is most important. And if the spontaneously breathing child can, they will be easily able to tolerate. And intermittently, if you don't, whenever you need to really oxygenate, that is the time when you have to increase and ask them not to use the laser. So this is one thing. And in jet ventilation, again, it is an intermittent ventilation and apnea thing that we can use. And these are the main thing that we use. And of course, the saline, this thing which is being kept to the, cover that cool the area is very important. Excess heat can be a problem.
Thank you, Jayashree, for your comments. Now, do we have time now for any other questions from the audience? You can ask now. Before we move to the next one, is a very short presentation. Deepa, you have to keep it very short. I think IPL is starting or started. I don't know. People need to go. Yeah, quickly sum it up. We always have this last segment where one of our younger doctors talks, and basically it's a summary of what's been talked about, just to reinforce the ideas, again, for the younger surgeons, and also comments from the senior panelists and the speakers.
Good evening, everyone. I'll just sum up today's session in few slides. I just want to share our experience and to tell how we can avoid this iatrogenic injuries. So there are various reason behind iatrogenic injuries. What we are looking today is about the intubation and the instrumentation. We have already discussed about the tube size. The tube size should be the as smaller as possible. The minimal attempts, if it is emergency intubation also, then the cuff pressure should be less than 20 in pediatric age group. Avoid the use of stylettes, and if you want to use the flexible guide wires, and the position of the cuff, whether it is in the larynx or the subglottic and the tracheal region, can cause the intubation related injuries. And as far as instrumentation is concerned, the traumatic insertion of the instrument, how difficult the airway is, the skill of the surgeon or the operator, and especially the airway stents, what size, what shape, how long you are going to use the stents, malpositioning of the stents can also cause iatrogenic injuries. And new modalities like laser, coblation, and microdebrider, if they are the device is malfunctioning, as Kishore Sandu sir said, can cause iatrogenic trauma. Then let's come to the intubation trauma. We have already discussed this in detail. What exactly happens, why these injuries happens? The major reason is the inadequate knowledge of anatomy. If you are in hurry, if you are in rush and you don't know the pediatric airway anatomy is different than the adult, then this kind of problem can happen. The subglottic region is the narrowest part in the pediatric age group, but in the adult it is larynx. So it's not only once you have passed the tube through the vocal cords, the job is done. You should keep in mind that narrowest part is yet to come, and be very careful. And the moment you get the minimal resistance inside, please change the tube size to the smaller one. So as we know, the intubation injuries have the wide spectrum from the posterior bands, the posterior glottic stenosis, the subglottic stenosis, the granulations, the ulceration, or the intubation granuloma, or the tissue bridges and ridges. So there are different cases that in one case with the band and the grade 1 subglottic stenosis, and in the another similar presentation with the band and the grade 2 stenosis was found. Then here is another case, the preterm baby which was intubated for more than 39 days. And the moment they tried extubation, child was getting desaturation, and mostly during the sleep hours. So here you can see in such kind of injuries, the circumferential injuries, which again tells you that why it is important to know the anatomy, the size of the tracheal lumen of different age groups, so that you can select the appropriate size of ET tube. And similarly, again, if it is an emergency intubation, the granulations can come. So it depends what stage of the trauma or the injury you are looking at. It can vary from 3 weeks to 3 months, and different kind of presentation you can get. So the take home message is, knowledge of the anatomy of the pediatric airway is a prerequisite for avoiding airway damage, and complication always seem to occur when there is time pressure. So there should be protocol in place for managing such situations. Then instrument trauma we have already discussed in detail, but I'll just put one single slide here about this. This is a case of bilateral choanal atresia in a preterm child where the neonate is very small, low birth weight. And here the surgeon is trying to focus to drill the atretic plate. And here you can see the drill and the instrument, the endoscope, both are in single nostril. And sometimes if you ignore this part, then this burn injuries can happen. Though it is not life-threatening, but it can give the pain to the child and to the parents. So you can do some avoiding measures by putting some plastic sleeves, which works as a thermal insulator, and regular washing with saline, and take small breaks to prevent this heat injuries. And different injuries like CO2 laser, we have learned in detail today. The microdebrider related injuries we dealt previously while JORP session, and balloon dilatation. So what happens when there is a device malfunction? Such kind of iatrogenic injuries can happen. So again, unfortunate consequences can happen to anyone, but such incidences should be recorded and shared with the rest of the team, with the expectation that a similar situation may be prevented in the future. And when equipment is well maintained and used optimally, it reduces the risk of injury. So again comes the decision making. Why these iatrogenic injuries happen? When there is a failure of case referral to the tertiary care center or the time, or to your fellow colleague of the different specialty. And whenever there is an inappropriate decision making, again intraoperative consultation, if things go beyond your field and your specialties. Lack of supervision, when trainee is performing any procedure and there is no supervision behind. And the case of lack of training, when unskilled surgeon is performing some procedures. So safe practices will come with the early recognition, early referral, and with appropriate diagnosis and treatment. So how can we avoid such iatrogenic injury? Is to avoid iatrogenic injury, like basic anatomical knowledge, visualization of the surgical field, optimized decision making for the case referral, and the referral to the tertiary care center, to the optimal airway team, and the instrument selection, how to select. Like today we learn which laser to use in which case. Then the discuss when in doubt. So whenever you have some doubt, discuss with your colleague, take expert opinion, discuss with your seniors to avoid such iatrogenic complications. So learn from the mistakes of others. You can't live long enough to make them all by yourself. So here I conclude my talk. Thank you so much.
Thank you, Deepa, for summing it all up for us. I need to thank the wonderful talks given by the speakers. Dr. Karthik, Balakrishnan, we really learned a lot from your talk. Dr. Sohit, excellent coverage of tracheostomy-related injuries. And then Kishore, of course, outstanding talk on lasers. Every time I listen to him, I learn something more. And he's very precise, and a lot of take-home messages in the whole thing. And the panel, of course, Michael, who's been kind enough to give up the Tour de France cycling, which he's fond of, and came and joined us. Dr. Moghira Siddiqui, thank you very much, Dr. Siddiqui, for joining us. You add value to our discussion, and please keep joining us every time. Dr. Ashwath, Dr. Pratap, Chandra, thank you very much for giving the perspective of the neonatologist and the pediatrician, and Dr. Jayashree, Deepak, Dr. Shyam, all of you. Thank you so much, and most importantly to our audience. Now, the important thing is please try to register for the International Airway webinar. And if you have any, whoever's registered for our conference, we'll do it for you. And secondly, all this money is going to go for charity, going to go for a charity which we have been doing for 18, 19 years. So thank you very much, and have a good night and a good day, depending on which part of the world you are in. Thank you so much, and thank you, Prahlad, for giving us this
one
speech.
more important thing. Do we
Sure,
have permission for YouTube to post it?
Oh yes. Do we have the permission of the speakers and the panelists to put this on YouTube so that it becomes a resource material? Thank you very much. You've always been very kind. It can be used a number of times. Thank you so much for the wonderful program.
Okay.
Bye-bye.
Thank you, sir.
Good night.
Thank you.
Good night, all. Thank you.
Thank you, everybody.
Thank you.
Thank you.